Mira and I talked about this last night. I changed my talk a little bit today because I thought the most important thing to provide you all with today was the new information, particularly the information on the results of our new studies that are coming out on plasmapheresis and what we have found retrospectively looking at what we've done over the last several years. Certainly, at Georgetown and in my practice, we don't do plasmapheresis as the only treatment for pandas. There's a lot of children who just get antibiotics, who get IVIG, and tons, like the whole gamut. But there are children who do not respond to those treatments, and they ultimately do need plasmapheresis. So we felt it was very important to look back and see how those children did. As everyone knows, there was the one study back in 1998 that was done at the NIH in which 10 children had plasmapheresis. They did very well, but it was not replicated or repeated in the United States for a lot of reasons, mostly political, and that has led to a lot of controversy. So the real issue that we wanted to look at was whether this was safe and whether it was efficacious. That was the primary goal of looking back. And also, we wanted to look back to determine whether the pheresis protocol that we used in the patients was safe. The pheresis protocol that was used at the NIH in 1998 involved doing one total body exchange every other day for a total of 10 days. And because these kids are so difficult, shall we say, a little bit hard to manage, and because they were so small, we really felt that we needed to put central lines in. And when we got together at Georgetown, we decided it was just not acceptable to put a central line in for 10 days, knowing that the risk of clotting and of infection after 72 to 96 hours just starts to go up significantly. So the Hematology Oncology Service came up with a protocol where we elected to do 4.5 full body exchanges. And we did them over approximately 4 days, 5 days max. And patients were brought into the patients were brought into the hospital and had a central line in place. They were followed closely. As long as their coags remained okay, we continued with once a day pheresis. Almost always we had to pause on the third day and wait for their coags to correct. So what was the indication for pheresis? The indication for pheresis in our center was severe refractory cases. None of these kids were going to school, although a lot of the kids are not going to school and they still don't come to pheresis. A lot of these children were IVIG failures, or they significantly relapsed IVIG without a significant response to repeat IVIG. So in my practice, if somebody fails IVIG, I don't then just go on to continue to give IVIG, generally speaking. If they fail IVIG, I say, why did they fail IVIG? And sometimes I will say, well, they must have an infection somewhere, and then I'll go looking for the infection. We do take a fair number of kids' tonsils out, and we have found, those papers are coming out as well, we found a lot of badly diseased tonsils, and there's a lot of contradictory papers as to whether or not taking the kids' tonsils out works. This paper that Madeline just referred to with the high immune complexes is interesting because after IVIG, the kids do flare. They flare about 3 weeks after IVIG, almost always. And now I always give solumedrol at a pretty significant dose when I give the IVIG, and they'll have this very quick response and say, it worked right away. And then 2 weeks later, it stopped working, I said, no, it never worked. It hasn't started to work yet. It was the solumedrol that worked right away. So, but if they're not responding to the initial IVIG, and they're very sick, or they're subsequently not responding to a repeat IVIG after the first one worked and they've had a relapse a year or two later, then we'll look at plasmapheresis, or if they have extremely dangerous behavior. And extremely dangerous behavior, for anybody who sees pandas, know exactly what it looks like. They're trying to jump out of moving vehicles. They're trying to jump out of windows. I had one child walk into the middle of the Potomac River, trying to hurt their siblings, breaking everything in the house, scratching their parents. The parents come in bruised from top to bottom, trying to hurt their doctors at times. And also anorexia with rapid weight loss. And I know someone else will talk about this a little bit later, but the anorexia is not a typical anorexia, I am fat anorexia. It's more like the anorexia that we see with Sydenham's chorea. I can't swallow, but suddenly, boom, you'll see a 10 or 20% weight loss in a month or two. And those children also spit, which is something that hasn't been, but they spit all the time. I think just because they can't coordinate the swallow. So the patient sample, and we had done about 100 patients over the course of several years, maybe 10 years at this point. But we selected a group of 43 patients, and this was done because we had an electronic medical record where everybody we could follow them, and it was a collectible group of patients between a given time period where the same people were in charge, we were using the same protocol. And it was between 2009 and 2014. Of the 43 patients that were selected, they were all diagnosed by me. They were treated at Georgetown University. And of the 43 patients, there were 32 patients included in the final analysis because in those 32 patients, we had adequate data. And the data included my consult notes, pre and post pheresis, the consult notes from the hematology oncology service, the inpatient notes, and a somewhat detailed and comprehensive interview with the patients over the telephone, in addition to the multiple messages that recorded in the charts. Now, I think this is a skewed population, and I will tell you why, and I think anybody who treats this will tell you. People who get pandas, who get better, do not want to talk to you ever again. So we had a significant refusal record of people who, when the intern called to try to get the follow-up, said, "We're fine, everything's fine. Everything's fine now. We don't need any more help. Everything's fine." And several of those children I actually know personally, and I've seen them, and they're perfectly fine. But we couldn't include them because we didn't have the detailed data. So we had 20 boys and 12 girls, and it's a ratio of 1.6 to 1, which is a little different than the ratio I think that's generally quoted of 2.6 to 1. All of the patients were sedated in our ICU. All of the patients were sedated with propofol, the replacement of a central line. We have an extraordinarily good child life service who works with these kids. And once the hospital knows how to deal with these children, they're actually not that difficult to deal with. If they approach their very hostile, aggressive behavior as though it's all driven by anxiety, the kids generally will settle down and feel safer. And the hospital there are some children who are afraid of men. There's a sign across the room, no men are allowed to enter this room. There's some children who are afraid of the color blue. Nobody in blue is allowed to enter this room. So they've really gone out of their way to make it a tolerable experience for these kids. But a total of 4.5 total blood volumes were exchanged over 3 to 5 days. The only problems we had during the hospitalization was, and they have a continuous calcium drip running, and we have an active transplant service too, so they do pheresis all the time. So it's a routine matter for them. Occasionally someone got a little hypocalcemic, they turned up the drip a little bit, it wasn't too difficult. And they monitored labs all the time. So the chart review again was done in detail, including my office notes, the notes in Georgetown, and the interviews. So the typical symptoms in this group was obviously the severe OCD, which if you take a good enough history, even in the most uncooperative, angry, hostile patient, you will elicit the OCD symptoms. The frequent urination, nighttime enuresis, severe separation anxiety, trouble sleeping, dysgraphia, aggressive behavior, severe anorexia, and motor and vocal tics. Of course, we didn't do plasmapheresis for tics, but those are the symptoms that we saw. And now the complications, this was the first thing that we wanted to look at. Complications of the procedure, there were two. One of these patients was the grandchild of a doctor, and I was there when he was given directions about keeping the pressure bandage on. They took him back to the hotel, took the pressure bandage off, put him in the bathtub, and he had some bleeding and had to come back to the hospital. One patient, so he came back, had put some pressure on the site for about an hour and then went home. The second patient had some bleeding at the site and required pressure and was monitored overnight. So that's 2 out of 32. That does seem a little bit high to me. And I think we have to review this as an institution, but I think we were so afraid of an infection or a clot that maybe we made these kids just a little bit too hypocoagulable, and we could have spread it out a little bit further. So these were the results. So in 30 of the children, 94%, they had severe debilitating OCD, and these children's Y-box scales were well above 25 generally, and the severe to extremely in a very high range. Following the plasmapheresis, and this data is taking at about 6 months pheresis, there were only 8 children had OCD, 25%. Separation anxiety, 21 had initially 75%, and these were the children who were sleeping with the mother, glued to the mother, sometimes naked on the mother in bed, and after the pheresis, only 9%. Tics, 61%, again after pheresis, 19%. Tics are not such a big deal. Frequent urination was present in 63%, and the frequent urination, as anyone who sees this knows, they go to urinate, they come out, they feel like they have to go urinate right away. And to me, I would be interested to see what the urodynamics look like on these kids because no one's looked at it, but it seems to me like there's 2 types of kids with frequent urination. Kids with urgency and kids who flood. So one kid who came into my office, he urinated in my waiting room, he urinated in my office, and he urinated in my examining room. But other kids just have their underwear is just wet all day long, like they're dribbling constantly. And I don't think that's been it's not been well explained. I think it's central, it's just not been well explained. Aggression was present in 59% of the children, again, 6% following pheresis. Initial insomnia, cannot fall asleep. A clear objective sign of Pandas, and interrupted sleep. These are 7, 8-year-olds waking up with night terrors, nightmares, unable to fall back asleep. Incidentally, melatonin is very effective in these children to help them fall asleep. High doses, 6, 8, 10 milligrams if you have to, while they're sick. Choreiform movements was present in 50%. I'm a neurologist. I probably see more choreiform movements than the psychiatrists or the pediatricians. So I think that's probably somewhat specialty specific, but 16% had choreiform movements following it. Anxiety was present in 41%, and that's low in this data, but I think it's got lumped under separation anxiety and other things. Behavioral regression, this is the children who are watching, the 8-year-old who's watching cartoons, sucking their thumb, 31% down to 3%. Psychotic features were present 19%. And these are the kids who had hallucinations, so they were seeing things. And one child had that falling pheresis at 6 months. Suicidal thoughts that they would admit to. Again, they can often will not admit to these things. Present in 16%, they were all gone. And the anorexia was present in 3%, and only, I did that incorrectly, obviously. I think that's 13%. And then only in one child following pheresis later on. Now there is one atypical child on that right side who skews the results a little bit, who had mild autism and then the abrupt onset of Pandas. But we didn't exclude anybody because we didn't want to exclude anybody because we did not want it in any way to be a cherry-picking experiment. We wanted to include everybody who had pheresis. So those are pretty impressive results. The relapses, early on, and this is very interesting and I think important information, there were 2 children who had, within a month or 2, dental abscesses. And they called and said, he's relapsing and he has a dental abscess. One was they were both out of state. They were treated with drainage, antibiotics, and then I gave them a 5-day pulse of steroids, and they both did beautifully. So I think that's one place to look for infection, and I had not been doing so, but I am pretty careful about that, because a lot of these kids just won't take baths, they won't get in the shower, and they're obviously probably not brushing their teeth. They did recover quite nicely. One child came in, and he had really, really severe Pandas, and came in, he was about 4, and he had a beautiful response to pheresis. He was back to normal within about 3 weeks, 3 to 4 weeks. And pheresis works very fast compared to IVIG. And he was bitten by something and then had a MRSA infection on his leg and relapsed, and he was 10 times worse after the MRSA infection. And the mother called, and at first was like, well, we'll just treat him and see how he does. And then she sent me a video, and I said, well, we can't just treat him and see how he does. No, he's really bad. So the pheresis worked, so we said, well, we really don't have any choice. We have to bring him back in and do it again, which we did, and he did fine, and he's been fine ever since then. That's at least 2 years ago now. There was one girl, and I'm going to go into her in a little bit of detail later, who relapsed after about 6 months. She's eventually responded to monthly IV Solumentrol and 1 gram per kilo of IVIG, but she's a little bit more complicated than that. Now, the most surprising and hopeful finding of this whole study was that we graphed these kids over time. The average length of time that they were sick before they were treated was 5.5 years, and the average age was 12.3. But there was no correlation between the onset of symptoms and the length of the disease prior to the treatment with regard to patient outcome. And I plotted that out. I couldn't reproduce the graph here, but it just looks like someone throwing darts at a dartboard. I was trying to prove that early treatment made a difference, and it made no difference. So at first it was a little bit disappointing, but then I said, well, now we have plenty of time to try other things before we have to jump into pheresis, unless they're really in a dangerous situation. So the specific cases reviewed were chosen, the cases I'd like to go over were chosen because they were the 3 patients with the heaviest disease burden. They were extensively interviewed, and the historical reports are extremely accurate, and the details are very vivid. But I'd like to go over these cases just to give you an example. So Samantha is one of now 10 children. There are 9 girls and 1 boy in the family, and 4 of the girls have Pandas, not unusual at all. She had a sudden onset described by a psychiatrist in the University of Virginia as the most sudden severe onset of OCD they had ever seen. Her symptoms were a sensory OCD, violence, frequent urination, nighttime enuresis. She was hearing voices. She had hallucinations. She was so violent, she had to be removed from her family's home to live with her grandparents. She was staying in a bedroom, having her food shoved under the door to her. She was afraid of taking any medications. And it was a point at which I just said to the mother, this is child abuse. We cannot leave her there anymore. We've got to treat her. We've got to get her out of there. And we managed to give her some antibiotics and steroids in her food. She got a little bit better. She was willing to come in to get IVIG. She had only a day of relief, probably again from the Solumentrol. She had plasmapheresis after 3 weeks, probably because she was a little bit better from the IVIG, and this is again not an unusual story. You give them steroids, they get a little bit better. IVIG, they get a little bit better, but they're still really sick, and then they'll kind of agree to do the plasmapheresis, because we can't bring someone into the hospital to do plasmapheresis unless they're safe in the hospital, because we've got other children in the hospital as well, and these kids have central lines in, so if they pull them out, it can be catastrophic. So after that, she was doing great. She left the room, she moved back home again, she went back to school, and then she had a flare, and then Mom elected to take her to a rehab facility. She did okay there. She relapsed a little bit. She came back and was treated with steroids, IVIG, eventually went to Duke, where they have an autoimmune encephalitis program. She was treated with IVIG and Solumedrol, eventually was retreated with rituximab. And now, I just saw the mom last week, actually, taking care of one of her other children. She's showed me a picture of her. She's doing beautifully. She's going to school. She's perfectly fine. Now, Sarah presented at age 4 with a severe and sudden onset of intense OCD, germ phobia, violent raging, and extreme anorexia. I gave her steroids, and they made her much, much worse. And when you give steroids, you have to always warn the patients about that, although it doesn't usually make them worse. It just doesn't usually do that. She was given IV, had a great response. She said, I feel happy again. I think she was trying to avoid going into the hospital with that response because she was pretty controlled anorexic. She was being treated for an eating disorder, given IVIG again after a relapse. And again, with the anorexia, the one thing that I always caution parents about with anorexia is if they're not drinking, you have to be very careful about IVIG because you're giving a highly proteinaceous, viscous fluid to someone who's not drinking. And if you're worried about venous thrombosis, you really have to be careful. They either have to have IV fluids or someone has to be closely monitoring the amount of fluids they're getting. She got worse after her IVIG. She became increasingly violent with the parents, threw things, broke everything in the house, attacked the parents while driving, opened the car doors on the Beltway around in the DC area, wouldn't do IVIG again, treated with plasmapheresis, and then she did very well. She had said since then had a steady increase in her grades. She went back to school. She's required a few little steroid bursts here and there, like 5 days of Solumedrol when she's gotten a little bit sick, but she's about 95% better, and she's now several years out. Noah's the child I just told you about. Now, this is the child who had the MRSA. He had his sudden symptoms. He couldn't sleep. He thought a man was going to kill his family, and he needed to stop him. So the mother couldn't shower. He was treated with antibiotics after strep. Symptoms improved. He had IVIG after several bouts of strep and a tonsillectomy. The IVIG caused all kinds of side effects. His sister had received plasmapheresis. And the mother preferred pheresis over another IVIG. He was given plasmapheresis, and then he had the MRSA a month later, and then had another episode of pheresis. He's the only child who's been pheresed twice, and he's done very well since then. And this is about his big relapse. That was bad. So the general conclusion that we arrived at is that plasmapheresis is a safe treatment in capable hands when done in a controlled fashion. Although we've been doing pheresis as neurologists forever. I mean, it's the gold standard for Guillain-Barré syndrome, for a whole bunch of other things. And it was only when the IVIG companies started making IVIG that we even thought about switching to IVIG. And I have, for any other neurologic condition, myasthenia gravis or Guillain-Barré, I have never had to give IVIG after plasmapheresis didn't work. For those other conditions, there have been other times when I've had to do plasmapheresis when IVIG didn't work. So I still think that plasmapheresis is the gold standard, but it's a much bigger deal. And if I'll just leave it at that. And despite the risk, now the one thing that we talked about with our ICU doctors, I said, what is the risk of putting a central line in a child? What is the risk of putting a central line in a child? And he said, well, there's no data, because the data on central lines are in septic children who are in the ICU because they're on death's door. So the data is that about 25% of them get infected because they already have infections. About 25% of them clot. He said, we don't have any data on putting a central line in a healthy child for 5, 7, or 10 days. Which is why we came up with this shortened protocol, because we were a little bit nervous about leaving them in for longer than that. That being said, I think we did it too quickly. And I would spread it out a little bit longer at this point. And we really didn't have any problems. So the other thing I think that was interesting is that there were no post-plasmapheresis side effects. No one had a headache, no one had nausea, vomiting, no one had all the post-IVIG stuff. Nobody got worse after plasmapheresis. With the exception of the 2 patients with the dental abscess, and I wonder if I made them a little bit immune deficient and then the dental abscess came forward. That's a possibility. Plasmapheresis did work in several children in which IVIG was either ineffective or only partially effective. And I didn't go over this, but we only had about 7 children who we had done Madeline Cunningham's panel, and it did show a trend in improvement, which may be even more significant in the entire population, but they were only done in children who continued to show improvement. But it was plasmapheresis, so if you do plasmapheresis on anybody, any antibody that they have in the system is going to go down temporarily, and then it just bounces back up again. So they would have to have been followed over a long period of time. We didn't have a grant to do this study, so it would have added an additional burden to ask the parents to pay for that study, so we didn't do it. So the other thing we were going to plan to do is try to get a telephone interviews with the remainder of the 40 patients that we treated prior to 2009. Georgetown did not have an EMR at that time. I did, they didn't, so it's a little harder to get the data. And we did do the Pandas scale on most of these children. This was a scale that was developed at the NIH as part of the, and that might be helpful to repeat, just to get some, like an objective number as to how well the kids are doing.
Thank you very much, Professor Latimer, for showing us another possibility of treatment in patients with these disorders. Plasmapheresis, as you correctly said, is part of the disease, part of the treatment of other neuromediated diseases. And usually it's performed on the most important cases, but highly selected, like in some forms of relapses of neuromediated diseases. Also in Guillain-Barré disease, in the most severe cases, plasmapheresis is indicated. Do we have to highly select our patients to perform plasmapheresis? Of course, the results are brilliant, but as you showed, but I'd like also to hear everybody's opinion on this treatment. I'd like to know whether there are questions before you answer this question on the selectivity, the possibility of highly selecting these patients. Alberto Spalice, please. Good morning. Thanks very much for this excellent presentation. Plasmapheresis, is it the last resort in terms of treatment, or do we have to use plasmapheresis a bit before immunoglobulins in highly selected cases, because plasma exchange in some selected cases seems to be preferable? Then I agree on the Pandas scale during the follow-up to see the type of improvement and try and target therapy in a much better way in these patients. Could you expand on this?
I think that in some selected cases, plasmapheresis is a preferable treatment initially. And in the patients who I think it is preferable initially, it is children who have severe anorexia because they're already dehydrated. And if you do IVIG, you could potentially be sending them home to a situation where they're not going to be drinking. So that's one situation. The other situation is in the severely aggressive, violent child, because we know sometimes children will have a flare after IVIG and get worse for a short time. So in some of those cases, I think pheresis might be a first step. In my practice, I usually discuss this with the parents. And pheresis it's a big deal. You're admitting the patient to the hospital, there's a central line, but you just have to present the options. But I think in some cases it's a first choice option. Madeline thinks about that.
I was just going to talk to you about the assays that you said went down or showed improvement with the improvement of the children. Even though you did it with patients that had symptoms, would you say that the CAM kinase was more reliable at predicting improvement?
Yeah.
So I think that's something, I don't know if Dr. Sweeto would want to say anything about that or not at this point, but at least there's some evidence from studies that we've all done that the CAM kinase may predict improvement, that it will begin to subside in its activity level back toward the normal in many of the patients. The other titers may become altered too, but I think the probably most reliable early predictor about improvement is the CAM kinase.
Madeline, there's one other question I would ask you or someone in the audience, because this comes up in my practice all the time. Actually, I don't have the answer, but I kind of have winged it a little bit. I would have to say is that parents say, how long do I have to keep them out of school after plasmapheresis? And I usually say a month or keep them out of school, yeah. So how long does it take before they become immunocompetent again and are able to go back to school? I mean, if it's the winter, I just say stay home until the spring.
This is on plasmapheresis.
Yes, after plasmapheresis.
So that's still close to your month.
Yeah.
From Athens, and I'm a 70 years old son mother. We found pandas before 5-6 years. And my son onset was in 4 years old. The first year with IVIG was like a miracle, but after the years, seems that don't work anymore. Do you think that plasmapheresis is a good something good for my son, that IVIG seems that don't work anymore for him?
That's a hard question to answer on the stage without having seen him.
Thank you.
It depends on a lot of factors and what's been done and what kind of IV. There's a lot of issues that I don't think I can answer that question. Plasmapheresis is an option. A lot of things are options.
Salve, do maggior spazio alla famiglia, io sono una zia, non sono una mamma, ma l'effetto è lo stesso. Volevo chiedere, in età adulta, cioè mio nipote praticamente ci siamo accorti di questo disturbo 3 anni fa, adesso ne ha 22, in età adulta, per quanto riguarda le terapie eventualmente, siccome noi abbiamo approcciato da poco a questo tipo di problema, stiamo cercando di fare gli step terapeutici con una certa calma. Secondo lei sarebbe meglio puntare direttamente alle immunoglobuline o utilizzare prima la sua terapia? Più che altro per quanto riguarda un fattore di età, anche perché il ragazzo ha un disturbo legato strettamente a un fattore di clima, quindi il periodo invernale è ingestibile, il periodo estivo è praticamente un sacco di patate immobile e senza reazioni. Grazie.
Oh, I'm sorry. I said it's a little bit of an unusual story. Why can't he be managed in the winter?
È perché ha un problema è aggressivo, è autolesionista ed è aggressivo anche con i genitori, molto con i genitori.
Oh, yeah.
Cioè l'episodio più eclatante è stato in macchina sull'autostrada, lui ha tirato il freno a mano e ne sono andati in testa a coda col rischio della vita e insomma di tutto, quindi è stata una cosa veramente molto forte. Questa forse è una delle più forti, però diciamo non si gestisce. Poi come inizia il caldo, il sole, il calore, lui piano piano abbassa i sintomi e diventa quietissimo tutto il periodo estivo.
Well, you would want to make sure that he's worked up completely to make sure that he has pandas. And there are a few other things in the differential diagnosis of pandas. We have to make sure children don't have central nervous system lupus and Sjogren's and a few other things. So.
We carried out the tests in Sweden. We had them made in Sweden for pandas. They proved to be moderate. Moderate levels, not really indicative of pandas. But dopamine 2 receptors are negative compared to dopamine 1.
Thing to do is have somebody who sees a lot of cases with pandas review his records for you and see if they can help you sort out whether or not it's worth pursuing or there's other neurologic tests that need to be done.
So tomorrow Trifiletti will see him and we'll see what happens. What about streptococcal infections? He had a small episode where he became he started being agitated, very nervous. We gave the antibiotic. There was a throat infection. We treated it with antibiotic therapy, and he's calmed down. Now he is as usual. As calm as usual.
Well, that's a good sign, but again, that's a reason why you don't want to take any one thing out of context. Somebody needs to sit down and take the whole story, get the whole history. It's very important that it's not misdiagnosed and that you don't miss something else.
Okay.
I would say, if I may, I would say that also the phenotype has to be defined. It's really a very special case, so I would say that we do not continue with discussion, not because it's not worth, but we need to better understand the phenotype. Yes, so further investigate and then decide. Well, I suspect it's not pandas, but it's my own suspicion. You know, you have to identify the phenotype first.
Youngster having pandas as well. I have just two questions. The one deals about the treatment regimens. Are there any biological markers which you perform before and at the term of the treatment in order to control the effect? Not only clinically, nothing to do. Your colleague gives the answer.
No, it's the same thing that we do with Guillain-Barré syndrome or myasthenia gravis or any other autoimmune neurologic disorder.
Yes. Okay. And the second question, you mentioned very shortly rituximab. Is there any experience with generally biologicals in these conditions is there any medicine in the pipeline for maybe future long-term treatments of this disorder? Thank you.
There is. At least, I don't know how many children have had rituximab at Duke. I don't know the answer to that. I know that there have been a handful of children that have had rituximab at Stanford University in California, and at Georgetown we have had 3 children treated with rituximab who were refractory, responded to plasmapheresis, and then relapsed, and then were extraordinarily sick. Extraordinarily sick. It was a desperate attempt to make them better.
Volevo sapere se...
I'm a pharmacist from Bari. Just a question. The Cunningham test, was it made after therapy with plasmapheresis or after immunoglobulins to see that the values had decreased as compared to the initial condition? Did you perform a test after the treatment with plasmapheresis or immunoglobulins?
I have about 7 or 8 patients who I did do the Cunningham panel both before and after plasmapheresis, before and after, but not on a long-term basis. And one of the main reasons for that is because many of these parents are financially distraught by the time they come to plasmapheresis. And you need a grant to do that study. Because keep doing it every month or 2 is not really necessarily benefiting the individual patient. It's benefiting science, and we can't ask the patients to do that when they're in that situation.
Ultima domanda, prego.
Last question. I have a question about the age. Maybe a patient aged 10 starts antibiotic therapy. Maybe children may have had sensory problems, only problems with the light, and then starting from 9, they may develop tics or OCD, so they start therapy only when the situation becomes clear at the age of 9 or 10. At the age of 9 or 10, can antibiotics be enough? Or the fact that you have discovered the disease after a certain time lag, does it require that you treat the patient with immune globulins because you have had a time lag before understanding what the problem was? Because initially there were just second-order symptoms, while from the age of 9 or so there was urgency, tics, OCD, etc., problems with writing, and all the indicators for a diagnosis of Pandas, so that it was only at that time that the disease was made known.
You ask an excellent question, and we don't know. When you go back throughout these children's pediatric records, you will often see a month episode of frequent urination or an episode of school phobia, and we just don't know the answer. We're trying to study that now, but we don't know the answer to that question unless someone else knows the answer to that question. So, the question was, if someone has sensory issues or tics at age 8 or 9, and then they present at 10 with their full-blown Pandas attack, do they all need IVIG, or can sometimes antibiotics work? Yeah, antibiotics can sometimes work at that point, according to Dr. Sweeto, which I agree with too, but it has to be studied more extensively.
Bene, ringraziamo la dottoressa Latimer e passiamo quindi alla prossima relazione. Un grazie.